Hey, good morning, everyone, and welcome to Euronurse, your go-to place for urology healthcare information. Welcome to the show. We meet every Saturday at 9 a.m. Central Time, and you can watch us on any of those things. We go and broadcast to all of those. Welcome to the show. If this is your first time joining us, be sure to check out our website at euronurse.com, the best place to go to learn more about the show. Also, best place to see all of our past episodes, 108 of those now. So be sure to join us over there. Want to listen to us in your car? I know a lot of you do because I look at the statistics and it's real easy. Go to our Euronurse Plus area. You can get our audio podcast on any of your favorite podcasting formats. This week, we're going to be talking about cystoscopy and what's your office protocol. I sent a survey out to a lot of you and you've answered it, which I appreciate. We're going to go over some of those answers. Let's go ahead and bring in our experts right now. Experts, welcome to the show. Hey, it worked, except for mine. There we go.
You'll be the host. Who cares?
Yeah, it doesn't really matter. Welcome to the show. John, you snuck in just at the last minute. I got you on. So
Sure did.
Hey, welcome everybody. Labor Day weekend. I can't believe how fast the summer went by. I'm going to kick it off with my introduction. Vic Sinise. I'm the host and producer of the show. Been involved in urology for longer than I care to talk about, but it does pay off because I have some extra knowledge sometimes. At least I have legacy knowledge. Go ahead, Lori. Give your introduction.
Good morning, everyone. My name is Lori Atkinson. Happy Labor Day weekend. I know we all probably need it and deserve it. So happy Labor Day weekend. I'm a certified urology registered nurse. I've been in urology since 1998. That is a long time. And I currently work for Northwestern Medicine in Geneva and Winfield, Illinois.
Welcome. And Jan, go ahead.
Good morning. I am passionate about helping urology practices reach maximum clinical and financial efficiency. To that end, I created the Thriving Urology Practice Facebook group. It is a free Facebook group where we crowdsource practice management solutions for your benefit. And I like to think of myself as a modern day Robin Hood. You see, I take from the information rich and give it to the time constrained poor, people like you. I frequently speak on the topics of coding, billing, revenue cycle management, marketing, and how to run your practices more efficiently in the era of declining reimbursement and rising overhead costs. If you'll be at the South Central section of the AUA meeting in October, I'll see you there. Otherwise, I will see you at the Urology Advanced Coding and Reimbursement Seminar in December in Las Vegas. I am John Lynn, a private practice urologist in Gilbert, Arizona, and I look forward to our discussion today about cystoscopies. Back to you, Vic.
All right. Thanks, John. I'm going to switch us over to our format. Now we're going to do it a little bit different. So normally you see just me talking or whoever the guest speaker is talking, but I've got all my experts on because we're going to discuss a lot of this. So today our topic is cystoscopy. What's your office protocol? And those of you that are watching the show, Lori, you'll be watching that comment box. Send your comments, questions, thoughts. What are you guys doing? I'd like to learn more. Those of you that filled out this survey that I sent, I appreciate that. That was really, I'll give you the history behind why I did this. So the reason I did the survey was I'm going to be speaking for the SUNA group in September. The end of September is our big annual meeting. Come join us out in Orlando. It's going to be at the SeaWorld. First time I think I've seen an actual conference at the SeaWorld. So anyway, I'm going to be speaking not once, but twice. I'm trying to catch up to John a little bit. He's always got a lot of speaking engagements. And one of them they asked me to talk about was setting up for vasectomy and for cystoscopy. Obviously aimed at people that are new to urology. And I started thinking, I know how we do it. I know what some of the research has shown because I've been part of the AUA SUNA white paper group that did white papers on prostate biopsy, reprocessing, and on cystoscopy. So I know a thing or two because I've been involved in things, but what's really going on out there? And I wanted more information. I think it'll make the talk better if I can kind of understand what I what I believe and then what's really happening out in the real world. So, and we're going to open this up to my experts who are on the panel. Anytime you guys have a thought or something during the survey, feel free to throw it in there. But I started off with a very simple survey, just asking what type of cystoscopy you're doing in your office. Again, you could have the choice in some of these questions to answer both. That's why you'll see 150% for the answers. But I think it's not probably a big surprise to anybody that flexible cystoscopy is probably the leading thing that we see done, and some rigid in the office. Anybody in the experts got an opinion on that? Seem pretty reasonable. Nothing surprising.
No.
No, I think rigid cystoscopy, sometimes people use it for their Botox injections. Some people use, when I perform urolifts in the office, I obviously use a rigid scope.
Yeah. So we're still seeing some of it. I was around when the first flexible scope was introduced, and I can't even think of how many years ago it was, but we had a urologist who loved to always be on the cutting edge, and he got the scope, but he just hardly used it. It was all the young guys that came up after him that really utilized it. Of course, now it's probably the standard of care in the office. Thankfully. All right. So then I asked who's performing cystoscopy in the office. No surprise, mostly MDs. Sorry about you DOs. I didn't specify. So physician done, but also a number of PAs and nurse practitioners. And this is fairly new, that the NPs or the advanced practice nurses and PAs are getting involved in cystoscopy. Any thoughts on that? Lori, have you seen any of that in your office?
I do. So yeah, our providers do mainly the diagnostic cystos. Our PAs, we have some PAs that actually do the cysto stent removals. They'll do a lot of those.
And John, from a urologist standpoint, what do you think about that?
Well, I think a lot of the urologists are worried about encroachment by the PAs and NPs in doing the things that we usually do. But I think stent removal's pretty straightforward. As long as you could get into the bladder, you find the foreign body, you use a grafter to remove it, not a big deal. But diagnostic cystoscopies, it does take a little bit of more training and experience in knowing what you're looking at. So I think in that case, the use is right on. But I know practices that are allowing the APPs to perform diagnostic cystoscopies, pretty much the whole suite of cystoscopies.
And I think as long as, they're properly trained and somebody is, there to kind of double check their work as they're learning, it's something that obviously there's no magic wand that they, utilize in medical school to make you guys better than they do anywhere else. So.
And nowadays you can record the video if you want to double check on the work of the APPs.
Yeah. In the old days, we had this, in order to share a scope, it had this other lens that attached to it. So you could look. I used to do that with one of our urologists. The problem is it really cut the volume of light coming through it quite a bit. So it really wasn't as good. Now with video, I mean, it's perfect. So, all right, let's get on to our next question. Thanks, Fran, for your information there. So who sets up the equipment in your office? So probably no big surprise, except that I can't spell the word assistant. But that most of these are being set up by the medical assistants, nurses. My big surprise was there's actually an MD who's setting up his own equipment. Kudos to that doc who's doing their own. The other group I probably should have allowed to find out who those are, but my guess, and maybe you guys can put it in the comments if you have actual information, is these are people that are just trained, that are non-nurses, non-medical assistants, haven't gone through any formal education in the medical field, but they worked, for a doctor's office and were trained. Anybody's thoughts on that?
Yeah, ours is mainly our medical assistants. The nurses will help out when needed, but then we do have clinical assists, like you said, who they're not certified medical assistants, but we've trained them to do that.
Yeah.
So we have some of those as well.
Good. And I got to say,
go ahead.
There's no judgment here. I'm not trying to say what's right or wrong. I'm just trying to find out what's being done. And I really made the survey. One thing I said is it's anonymous. I don't track any emails. I don't know who sent the information. And I really think I got some true, honest answers, which is helpful. Go ahead, John.
Oh, I like to remind people that the physician and APPs are the most expensive employees in the practice. So when we say that you should be operating at the top of your license, I always think, can somebody else do the tasks that I'm doing? And if the answer is yes, then I should not be doing it. I should be doing things that are more productive in the practice.
I agree, and that's why I really think that's the perfect example where medical assistants are the right person to be doing that. You know, if you're putting your registered nurse taking their time at their hourly salary to reprocess equipment, that's probably wasted money. So, all right, good,
Oh,
good
we've got some
information.
comments on that, Vic.
Oh, good. Go ahead. Let's bring that back. I'll bring that
So
slide back up.
Raji says they have a surgical assistant.
Okay, so that would be probably in that other class. Great.
You use mainly LVNs. We do have scrub tech for cysto cleaning purposes. That's from
Good news.
Nisha.
Good information. Thanks, Nisha.
Oh, she meant text. I kind of thought that she meant the text. So
Good. All right. Well, thanks. That was some interesting information.
And I think in this, the subtext in performing cystoscopies is that depending on where you practice, your ability to do certain things may be limited, and also depending on the state in which you practice.
It's going to vary. You're right.
Yeah, California, I think, may be a little bit more restrictive on who can do what.
Yeah, absolutely. It's been a long time since I did the research, but when we started adding medical assistants, I researched for, practice acts. The only state I could find a practice act for medical assistants is California.
Yeah, it's interesting you say that because at the SUNA conference, I'm actually going to be speaking. We're doing a position paper on MA I'm on an MA task force, and we're actually talking about the fact that a lot of medical assistants, even though they're allowed to do these things, there's nothing to back it up. There's no, protocols or training devices, things like that. So we're working on that. So if you go to the SUNA conference, you'll learn more.
That's right. All right. So the other one I asked was the setup that you use in your office. And this one I was hunting for some conversation. Sterile field, sterile gloves, total sterile setup versus non-sterile setup like a chuck pad and non-sterile gloves, procedural gloves. And we can see from the statistics that the bulk are using a sterile field, sterile gloves, but there's a small percentage, well, not maybe all that small, almost 10% that are using, something besides a sterile field. Now, being on the white paper for this discussion with, physicians, urologists, and nurses together, kind of arguing this thing out, I have to say there is one point that was made during the talk when I was doing the ultrasound white paper, is this part of the instrument really is not necessarily have to be sterile, because they said, where do you draw the line at sterile? How far do you have to be gowned up and everything to do a cystoscopy or prostate biopsy? Because the part that goes in the patient is the catheter side of it, not the handle per se. And I'll bring up my experts to kind of get your feeling on that one. What do you think about the setup? Does it have to be completely sterile, or just keeping the tip sterile, or the catheter side of it sterile? Lori?
No. So, I mean, if you think about it, most places clean their scopes with a high level disinfection. It's not sterile.
Right.
The procedure itself is not considered sterile, and that's AUA guidelines as well. So we do a high level disinfection, but as far as our procedure is concerned, we do not do it sterilely. So we have the chucks and the regular gloves.
Good. And again, I can see the argument. John, what's your thoughts?
Yeah, I'm with Lori on this one. You do not need to make it a sterile type procedure. And very importantly, we worry about infection risk. And I will tell you, the infection risk is extremely low, even when you don't use a sterile type of setup. So I think a lot of practices are wasting a lot of money and resources when they are setting up this entire sterile field. And whoever's handling the instrument is having to use whatever precautions necessary. I think that is overkill.
Yeah, I agree. And that's what we came to as a conclusion in our guidelines for prostate, that, there's a certain point of it. You don't need to have a sterile glove on to use the ultrasound probe. That part that's you're holding is not going into a patient. So, it's all kind of using good common sense, which we know doesn't exist too much anymore. But
Wait. Let's think about the transrectal ultrasound. Go on a tangent a little bit.
okay.
Into which orifice are you inserting that ultrasound probe?
That nice, that non-contaminated rectum, right?
Whatever. It's
Yeah. Good point. I can't in the comments, if you guys want to also make a comment about how you like this format. I really thought of this as I think it's fun to kind of be able to go back and forth with people and get opinions. But anyway, going on. So now I did ask a question about what size sterile bag do you use for cystoscopy? And there's really 3 out there that you can use: 100 cc, 1000 cc, and a 3000 cc. And those are the ones that, excuse me, for sterile water that we order. And I was glad to see that nobody's using the 3000. I put that in for a reason, and I'll get to that in my next question. As far as the 1000 versus the 100, though, if as a cost basis, they're pretty much the same cost. So most people do use 1000. We use 1000 for that reason, because sometimes I can get 1000 cc bag for less than 100 because there's just larger numbers of those sold. So I don't know, is anybody using anything different or heard anything different in your practices? Then
I know that we actually use 250s. I mean, we'll
never
use
saw that.
Yeah, we used to use 1000, and maybe we still do on certain types of procedures, knowing that you're going to use a lot more water, but there's no reason to use thousands. That's just kind of a waste.
It is a waste, except financially, because
Yeah.
a lot of times I can buy 1000 cc bags for less than the hundreds.
Yeah.
So,
And Susie said they use 500.
So live and learn.
And
See,
Rajesh says 500 as well.
Nice in the middle. Now, the reason I asked the question was this one: do you reuse the same water for multiple patients? Thankfully, most said no. Some said yes. Now, that one I do have some research on. So before I turn it over to my experts, I will say what I could find. And there was an article that appeared in the British Journal of Urology that said, do not reuse your cysto irrigating equipment. Excuse me, boy, allergy season. And what they're looking for is, does the system reflux? So they put a sensor in there that could detect if anything was coming back up retrograde. Interestingly, in their results, they found that there was reflux and irrigating fluid in 11 male patients, and was significant in 6 of the 65 patients they tested, but there was no reflux found in the female studies. Their conclusion, though, still said infection control measures must include the prevention of transmission of blood-borne infections, especially hepatitis. It takes very little blood to cause hepatitis transfer. So from their evidence, flexible cystoscopy should always be performed with single-use irrigation systems. So, what's everybody's thoughts on that one?
Well, Vic, like you and I have been in urology a long time, and I remember when we used to reuse the water. I mean, we would do it after cysto until they figured out, and it makes total sense, because as you're doing a cysto, sometimes you'll see them reflux, and you'll see that urine go right back up that tube. So it makes 100% sense. So yeah, we don't ever reuse.
Yeah. There's no anti-reflux valve built into it. I'm with you. When I joined the practice, I was the first nurse they brought in, and I'm sitting through a cystoscopy. I'm like, how is this safe to use the same bag? They go, well, it doesn't reflux. And the patient I happened to be in was a bloody case who had a bladder spasm. And I said, it doesn't. And as you can see, the red going up the tube. Being won that argument, we switched over to the single use. And John, I see you shaking your head, so I'm glad to see that our urologist in the practice is agreeing with us. So let's stop that now. You folks out there, go to your people in charge and tell them, no, there is show them the research article. So, all right. The next question, this one I just threw out there, just kind of interested. Do you use lidocaine jelly for male patients? And also the converse size, do you use it for female patients? and most are getting, most of the men are getting some lidocaine. Half of the women are, half aren't. Not sure why, the males would need more or get more or less. I know this is a controversial subject. I've argued this one with a good friend of mine, and her opinion is, there's no good science to support the use of lidocaine. However, I don't care about good science. I'll give you some bad science. I have to go to get my teeth cleaned, and I've had a hygienist do it without the topical. That's like a 9. I had the topical 3. So I'm all for it, even though I've never had cystoscopy, so I can't comment. John, what are your thoughts?
Well, I'll give you the answer as to why men need lidocaine, because we're big sissies.
Yep.
Most men are overly anxious, and we never had menstrual cycles. We never had cramping and bleeding. We're not used to seeing doctors. So anytime a guy comes in for cystoscopy, vasectomy, we're like, oh, no, don't do anything to me.
Yep.
And that's why I think the placebo effect of viscous lidocaine is extremely strong. That said,
Yeah.
I think if the urologist or whomever is performing the cystoscopy is good enough, viscous lidocaine is not necessary, irrespective of gender.
I think that's a good, valid point. A placebo effect, don't underestimate it. It makes a huge difference, especially if you can sell it. Oh, don't worry, we're going to give you a local. Oh, okay. As long as they know they're getting it, then they're a lot better off. Lori, what are your thoughts?
Well, I wanted to bring up a comment before I say what I'm going to say. So Susie said 10 years ago, we never used Lido gel on females, but we do 100% of the time now. So we used to use Lido, Glido, whatever you want use on males and females. We don't do it on females. We do it on males, not only for the placebo effect, but I think because of the lubrication. So I think that it's just, I think that the scope would go in easier. Now, let's be realistic. The lidocaine probably doesn't get up to the part where men are going to go, ow. I mean, you're not going to get away from that. But yeah, it's definitely more of a placebo effect. And with females, they, as long as you don't tell them that, you have the option, or, it's just a little pinch for them. Why put it in and then give them another little pinch? There's no point. So,
yeah.
And if you're going to use lidocaine, the only thing that's going to make it work is if you wait. The dwell time is what's important. So if you're going to use it, like for instance, the physician or APP inserts a viscous lidocaine and immediately goes to cystoscopy, that's a total waste.
Yeah, that's a valid point, which actually brings me up to my next comment here.
If
Go ahead.
person is really that anxious about cystoscopies, then consider using nitrous oxide.
Yep, Pronox. It mellows them all out.
Or Nitronox Plus.
Yeah. Yep. So then I asked the question, if you use lidocaine jelly, who's administering it? And not by any big surprise, it was, and again, it could be more than one answer could be correct. So nurses are by far the ones administering it, followed by medical assistants, physicians, and NPs and PAs also, plus the other who we're thinking are probably techs. Probably not a big surprise that NDs, PAs, and NPs are doing it, but I think, as John had said in his comment, that it's probably given and then they go ahead and scope. I don't think they're waiting. The advantage of having somebody else give it is normally, like in our practice, we go in, we give the Lido, we put a clamp on and walk out and let the patient dwell. And then the physician, by the time they get in there, that stuff has done its job. And it does make a difference. You can tell if somebody's had it in there for a while versus someone who just gives and goes.
And to anyone who actually is listening and doing cystoscopies, the key is to, for the males at least, when you get to the external sphincter, just wait a few seconds there, talk to the patient, get him to relax a little bit. I tell the patients to relax your buttock area, relax your back, relax your legs, and then the external sphincter will open up. He'll relax, and then the scope just goes right in. That's the key area, I think.
Yeah.
So I have a couple.
Go ahead.
Sorry. So Nisha said they're using lidocaine for both. And then Tavo says, I believe lidocaine helps based on patient responses. I insert it in our patients and we wait at least 10 minutes.
Good practice. Hey, and thanks for you guys chirping in there. I know we have a pretty good crowd here watching the show, so I appreciate all these comments coming in. A word back to what John had said. So I got called in. One of my responsibilities when I was rounding in the hospital was to put catheters in when they couldn't get a catheter in somebody. So I went in to put a catheter in a patient, and the guy said, listen, 3 people have tried this. I've had enough of it. And as John said, one of the problems with anxiety is they tighten up, and they can tighten that sphincter up. And what people were doing is they're trying to push against this guy who was fighting them. So I kind of learned how I could rest my on the hand that wasn't sterile kind of against the inner thigh where you can feel that muscle in their leg.
Yep.
And I would tell them, now relax. And even though you're telling them, they don't always relax. As soon as I felt that muscle relax, I pushed the catheter and it went right in. So I told him, I said, I'd get this in one shot or I'd call it quits. And of course, then every time he saw me, he'd say, hey, 1 shot. So it's true, as you said.
Same thing when you're trying to put in a catheter, if you're trying to perform a cystoscopy, or if you're trying to perform a vasectomy. Now, in the last 3 years, I performed about 3,300 vasectomies. I have a little bit of experience. What was that?
But who's counting?
Yeah. It's with and also with no advertising. So I have a little bit of experience in doing this procedure, and what you said, Vic, is exactly true. One of my hands or both of my arms are resting gently on the patient, and you can feel when the calves are tightened. And I don't tell the patients to relax. I tell the patients, you feel how tense you are down in the pelvic area, down in your legs. I want you to do the opposite of that. A lot of people don't quite get relaxed. Okay, relax. Do the opposite of what you're doing right now. See how tense you are. Feel how tense you are. There's a little trick for you.
Yeah. See, look where you're going to get tips like this, right? From the experts. So yeah, no, it's true. And John, you don't have to advertise. When you got word of mouth, that's all you need, right? Good results are going to bring in plenty of customers. So I think
good product is key. A lot of people say, how do I do more of this, more of that? I tell them you have to start with a good product. And the mindset of continuing process improvement, or Japanese phrase called kaizen, is imperative in irrespective of what you do in the office. You have to think about, how do I do this better the next time? And that's how I'm able to do vasectomies in under 5 minutes consistently.
Yeah. That would make a big difference for who I picked. That's for sure. All right.
It's interesting. And sometimes the patients will say, why am I paying you so much money to do a vasectomy? I tell him that you're not paying me this money to do the 5-minute procedure. You're paying me all this money for the 30 years of schooling and experience to get to where I am.
That's right. Exactly. People don't always like to think about that. It's the me generation. All right. Now, getting to the meat of what we're looking at, because this is a lot of what I'm going to talk about, is who reprocesses cystoscopy equipment after your use in the office. And again, probably not a big surprise. Medical assistants and others are the primary person doing it. As we kind of spoke to it, that's probably who should be doing it. Still some nurses out there are doing it. Nurse practitioner. I'm guessing it must be a real solo practice because, as we said, it's not the best use of money in today's economy. That does matter. Not a big surprise. MDs, PAs showed none, but of course, small sample size will also have some of that effect. But I wanted to see who's doing it, because my next question was, who trains the employees on reprocessing equipment? And so I gave what I thought were the most logical choices: a supervisor, the person in charge, fellow employee, the company. Some of the companies I know do offer training on their scopes and what they tell you to disinfect it. And then I threw in that no training offered. And that's the one that to me is a little scary. Not surprised, fellow employees training other employees makes a lot of sense. The cystoscope companies having somebody who can talk about it. But the no training part, that to me just seems crazy. Lori, you have something set up for new employees for reprocessing?
Yeah, so I'm actually a supervisor, so I can tell you that I can show somebody, but in my opinion, the best person to show is somebody who's been doing it a lot. And so, because I'll go in there and, I haven't done them in weeks because I've got other people doing them, it just makes sense. But I do, however, make sure they're doing it correctly. And we do have a protocol and information and make sure everybody's doing it the right way.
Yeah. And John, do you have a protocol in your office for who trains?
No, we just grab whoever's off the street and we say, go
Oh,
clean
so
up.
you're that 10%.
No, actually, we have a combination. So we have supervising person who can oversee. We have a fellow MA to train the new MA on how to process the endoscope. And we recently had Olympus come out because we use Olympus scopes, and their reps also trained us. In addition, we have a guide posted where we perform reprocessing, and it's a flexible endoscope cleaning and disinfection guide. So we don't rely on memory, we don't rely on dogma, we follow the protocol.
Yeah, and we all know that, all of us here on the panel know, and certainly probably most of the audience, the danger of not reprocessing these things properly. If they're not reprocessed properly, patients can become infected, and that's not a good thing. Even not cleaning and getting the disinfectant off of them, there's been some cases of cystitis from the chemical burn, chemical cystitis from the not processed. And yes, Rajesh,
The
I see that.
disposable scopes, yeah, they use disposable, which we actually tried a few weeks ago, only because one of our we were lucky to have this machine called a Medivator to do our high level disinfection for our scopes. The problem is those machines break down, and so to have on hand, we have the disposable scopes, but they're expensive. They're very expensive.
And they're going to be unaffordable next year unless something changes with the physician fee schedule that is proposed by CMS.
Yeah. And they always try to claim that if you look at the cost of your high level disinfection and the employee to do it and all that, you add it up. But I don't know. It just seems like it's a nice idea, but I don't think it's workable. There was a company that used to make a sheath that you could put a scope into that was sterile. And the cost of the sheath, though, was so expensive that it just per cysto, as you say, with reimbursement dropping, doesn't add up. I did want to talk briefly about reprocessing medical equipment. So I'm going to bring up full slides here for a second. This is nothing new. 40 years ago, Earl Spalding came up with this classification scheme broken into 3 categories. Critical items, which are the things like surgical equipment, they're considered number 1. They should be, recommended sterilization unless they're heat sensitive. So that's anything that enters sterile tissue or the vascular system. Semi-critical items, which is what cystoscopy falls into, come in contact with mucous membranes or non-intact skin, require high-level disinfection with a liquid disinfectant. There are no flexible scopes I'm aware of that you can heat sterilize, but there are cystoscopes that are autoclave safe. We have some of those in our office, and we autoclave those. Non-critical items like your stethoscope and blood pressure cup are considered low level, and they can, or non-critical items, and they can use low level disinfectants. We use these PDI Sani wipes, and if you look, they kill just about everything. So I mean, still a good disinfectant, but you don't need to have that high level that you do with the other equipment. So at that, I brought in the question of which disinfectant do you actually use? And no big surprise, glutaraldehyde was the kind of the number 1 in the chain. Some of these other ones like the OPAs, the Sterile system, which I've never used, but I know that's a complete reprocessing. Medivator, Laura, you said you mentioned you have that one. So I haven't seen it, so it's a low percentage. Some of these comments, I did allow comments, so I was reading through, and some people are sending them out to a company to have them reprocessed in between. So there's some off-site reprocessing of the equipment being done. I think most people are reprocessing their scopes in their office. John, do you reprocess in your office, or do you send them out?
Oh, yeah. I think the most efficient way is to reprocess it in the office.
Yeah. I think unless you're like connected with a hospital and using their systems and they're taking care of it through their central sterilization system.
Well, then if inefficiency is built in, so that's
absolutely, yeah. All right. So good. Glutaraldehyde we know is the number one because it's been around for forever, since the 60s. The one thing I did want to mention, I think it's important, is the OSHA does, OSHA is the one that protects us, the user of this stuff, against getting injured. And OSHA is a product that requires some care with the use of it. The most serious side effect is the vapor. You can, inhale it, and it has some bad side effects from that. You can get on your skin dermatitis. Your eyes can be irritated. Your nose can be irritated. There are recommended exposure controls, mostly to make sure that you're having this level of glutaraldehyde in the room. Those of us that worked it with it, you know how it smells. It's not very pleasant. And if you build up high concentrations, that can actually be dangerous. So I asked the question, do you have a ventilation system or fume hood specifically designed for safe handling of high-level disinfection products in your office? And it was almost a 50-50 mix that do and don't. We do, I can tell you that, because it does build up. Back when I started, there was a product called Sporicidin, I believe. It smelled like mouthwash. It was very pleasant, and we didn't have anything in there, but it got pulled because it wasn't strong enough. Then we switched to glutaraldehyde, and I'm like, whoa, this stuff is really strong. We had a small room that we did it in, so we certainly didn't have enough air volume. So we switched over to one of these fume hoods. It's amazing. You don't smell it at all if you got one running. Lori, what are you guys? Well, you guys are sending out, right?
Well, since we have the Medivator, so it's in the office. It's a chemical called Reprocessing. We don't necessarily have to have a hood for that. It's all in this machine. Although I want to stress how important it is when you're dealing with these chemicals. You should be wearing a gown, goggles. You should be wearing gloves that cover, because these things are potent, and don't take them.
Yeah.
Don't take them for granted, because we have had some accidents with these, and it's no joke.
Yeah. That's where training comes in.
Mm-hmm.
And John, what do you guys use in your office?
We have a dedicated fan in each one of the rooms. So the fan is constantly running. Whenever the day starts, the fan is running.
Yep. So again, the room we had was a small room with no ventilation.
Yeah.
Exhaust, so it's sucking out the air. You need to have something. And I'm going to probably just bring up my next slide here. There are systems that you can purchase for your office that can detect how much glutaraldehyde exposure you're having. And it's not very expensive. Somebody can wear a monitor, send it in, and make sure that your air exchange is there. Do you have to have a hood? No. The hoods work. I'm just telling you that they're very effective. I've done it with the hood, and it's like doesn't even show up anything. But keep your levels within the normal. As Lori had mentioned, gloves, safety eyewear, gowns, lab coats, those things should be worn, because you don't want to get this stuff accidentally on yourself. The worst thing you can do is spill it on your scrubs, and you got nothing else to put on, right? Poor practice can lead to exposure. And the next question I asked was, do you have a spill kit if you're using glutaraldehyde to design for high-level disinfection products in case you spill? Now, I was really surprised by this one, in that most do have the spill kit, because it doesn't happen very often, but boy, if it ever happens, you have a spill in your office, that stuff, you have a lot of surface area to kind of get out and spread the fumes. The spill kit, you just throw this, it neutralizes it, and it just disappears. Plus, it has all the equipment you need to kind of soak it up. Again, Lori, I don't know if the Medivator, if there's some kind of spill kit for that or not.
No, but one thing I can comment on that is make sure you have your MSDS, the safety sheets, available. Yes. Because when that happens, you need to have that nearby to know exactly what to do.
Yeah. John, you have a spill kit, or you're running out to get one?
No, we process everything in the same room, so any sort of minor spill is easily contained.
Yeah. No, and this, I think, is looking at a catastrophic. Somebody drops a tray of Sidex, for instance. That would be where you need a spill kit. The couple of drops is you're dumping it. Probably doesn't require a spill kit. So.
Oh, this is interesting. So, Fran, I want her to elaborate on this. A while back, we needed to wear a monitoring badge.
I'll bet you that's the one I was pointing out, that glutaraldehyde badge.
Oh,
Because yeah, I mean, it's like I said, it's fairly inexpensive. And I think it's nice to have that documentation, because if somebody says, hey, I developed this because of my exposure, you can say, well, wait a second, we're within safe levels. So sometimes you're just, covering your butt.
And keep in mind,
So
speaking of covering, whatever the scope is soaking, there's a lid over the tray. So you should
yes,
always have that on.
yes, that's a good point, because I have seen where people don't cover it and it's open, and that stuff,
Yeah.
you're spilling it into the air. So definitely should be covered to minimize the amount. And I think it's simple enough if you do these things to keep it within good levels. And I said about large spills should be contained. And there's a product out there, and I was curious if people use it, called Glued Out. And mostly it's used for when you're getting rid of your old glutaraldehyde. And it just, when you're pouring it, there's a little higher level that you could get. The Glued Out will take it and make it neutral, so you don't even smell it. Most people don't use it. Some do. So I think it was kind of a 3/4 were not using it. I don't know of any requirement that you have to do this, by the way. And there's nothing I could ever find that said you can't dump it down a municipal sewer line. So I don't know, any thoughts that you guys have on
I have
disposal of?
a thought, a comment on that, is that make sure that when you're dumping these chemicals, that you're watching what other chemicals you dump down that same sink, because there can
Yeah,
be reactions that
reaction.
occur.
Yeah,
Interesting.
yeah. All right. So that's what Glued Out looks like, in case you haven't seen it before. You just dump it in there. It turns it to something that doesn't even smell. And you want to, of course, be careful when you're dumping it, that you're not splashing it and you're minimizing any contact with it. Our particular system, that hood, has a pump built into it. You just stick the tubing into it and it sucks out the stuff and puts it right down the drain. So next thing I asked is this question: how often do you test your high level disinfection with a test strip? And got a variety of answers: daily, weekly, don't use. Kind of surprised on the don't use part, but again, the study isn't exactly perfect. So I don't know if don't use means that they're dumping their solutions every day, or what they're doing to not be using a test strip. But it is recommended that it's tested, because even though on the bottle it says 28 days or whatever the length of it is, it'll tell you that, with repeated use, if you're doing a lot of cystoscopies, it'll lose its effectiveness from being diluted from the scopes being put in and out of it.
Yeah. Even with the Medivator, we have to test strip with each scope that we run. So every time we do a scope, it's not just daily, it's every scope.
Every scope. Wow.
Hmm.
And John, any thoughts?
Now, I'm going to have to claim ignorance on that. I don't know how frequently that is tested.
Yeah.
I think we are dumping the solution out every single week, because we do so many cystoscopies, even though it is good for, I don't know how many days, 14 days or 28 days.
They're 14 or 28. Yeah.
Yeah, we're changing that out very frequently, because
Yeah.
we're doing cystoscopies pretty much every single day.
Yeah. So it's something to look at, something to think about, because it may be worth, even on a weekly, if you're using solutions for once a week, run a test strip. At least know that your chemicals are good. Then I think once you realize what your process is working, that's something you can rely on. It always helps to have something like that cover. I'll talk about how you can cover yourself by in a little bit here. So the other thing I asked was, how long do you soak your scopes for in your high level disinfection? And I went from 1 minute up to an hour, and you can kind of see there that the bulk of us are doing the 20-minute soak. Some are doing 10 minutes, some are doing the 1 hour soak. And this is really kind of just a loaded question, because it really doesn't depend on what I think you should do or what you think you should do. It's really what the chemical says on the bottle, because they all have different soak times. And
That's exactly right.
you have to read the bottle. And the only reason I brought this question up was I had an incident where we've had some changeover in the people that are in our practice now that are involved in this. and we ran out of the solution we needed to soak that we normally soak our scopes with. And we use this new stuff called alcohol, which is alcohol and Sidex mix, glutaraldehyde mix, and it's only has a 10-minute soak time, so it's a lot quicker. But they brought something else over, and I asked the girl who brought it over from this other office, how long do I need to soak it? Now, I knew that this was a loaded question. I wanted to just to assess her, because that, as a supervisor, that's what I would do. And she says, oh, 10 minutes. I go, really? I says, where do you get that from? She says, well, they're all 10 minutes. I said, read the bottle, please. So, of course, I read the bottle. This bottle, I think it was a 60-minute amount to cause it to have high-level disinfection. So whatever you do, read the bottle. It doesn't matter what we put in a survey or what we say. It depends on what solution you're using, because they're all different.
And you also shouldn't soak them for longer than what it says, because it could cause damage to the scope.
Yes.
Yep. Yeah,
That's
the quickest
exactly
way to ruin scopes. Yep, exactly. They fog up the lenses. We had that happen too. So yeah, everybody, if a little bit's good, a lot's got to be great, right? That mentality. So
or you get busy. You walk away from a soaking scope and you get busy with something else, and then have egg timers as simple as
I
that.
just say that's what we do. Is we set timers.
Yeah.
Just for that reason. Yeah.
We have a timer that is going off, and that's how the MAs can hear throughout the back of the office, and they'll remember to remove the scope.
All right. So I just want to make a point. After you use a scope, it should be cleaned immediately to get most of the contaminants off. There then is a more thorough cleaning before it gets sterilized or disinfected. There's a product called enzymatic cleaner that's out there that we use it. It's a product that will break down proteins, so it's really good for getting blood, which is on most of the scopes and stuff, off. But it just gets a cleaner scope. Do you guys use enzymatic cleaning, or?
I love that stuff.
Yeah,
we have. So we're kind of high tech where we're at. We're lucky because when we moved in, we were brand new to urology, so we kind of got what we wanted a little bit. So that's why we have this Medivator and things like that. But we actually have something, it's called a Scope Buddy, and it's Intercept that actually pre-cleans. You connect, they've got connectors to the scope, and it cleans, and it goes through a cycle and runs things for 60 seconds through that before we even put it in the Medivator. So we're lucky we have a pretty
hey, Lori, you have to connect me with the rep for that company. I'd really like to have
absolutely
come on and do a show for me, because I'm interested in some of these more automated system. I'll tell you another quick story about the enzyme solution. So, of course, being the fact that I was on a white paper in urology, my name was on it. I got called as a consultant for a company that was doing procedures, and they had a high infection rate. And they said, would you mind coming in just checking over what we're doing? We don't understand why we're having patients, higher than the norm developing infections. So I looked at their whole process, saw who was doing the procedure, how they were doing it, and they were using the enzyme as a sterilizing solution. They thought it was something that would kill off bacteria. And I said, enzyme does nothing for bacteria. All it does is get dirt off your instrument. So sometimes it's scary what you can find out there, but yeah, good stuff to clean.
Hey Vic, so we've got some questions. I think this is great that Tabo and Susie kind of brought this up. So Tabo, I'm curious to know, how do you clean the patients for cysto? To use iodine swabs or surgical scrub? And Susie said they use Hibiclens. Now I can tell you, Susie, that recently we would use Hibiclens as well, but Hibiclens is actually not recommended in vaginal mucosa. So we actually switched to betadine again. And so because that was something that we used all the time until, I don't know how it got brought up, but we found out that it's actually not good for mucosa.
That's a good point. And I didn't ask a question on that part of the prep, but that's another area to think about. All right, because we're running short on time, I want to make sure I finish up a few things here. So autoclaves, we mentioned sterilizing. I just wanted to make sure that you're aware that sterilizers, if you have an autoclave in your office, make sure you know how to use it. It needs time, it needs pressure, and it needs temperature. And it has to reach all those things in order to cause sterilization. So you should have a way to monitor that. You also have to be careful because super pressurized heated steam is super hot. And that stuff is, you know, you can get a serious burn if you try to take something out of a open, freshly opened autoclave too soon. And there are monitors. I have the Cydex strip there for some reason, but just to kind of show, there are monitors for whether your sterilizer is working properly either. So even the fact that you're sterilizing something doesn't necessarily mean that it's sterile if you're not getting pressure, time, and temperature. So there's strips that can tell you whether it's reached the proper temperature. There's strips that can tell you that it's reached the proper pressure. And you can do something that's called a spore test, which is that thing on the 3M has over there, which shows whether it's killing spores or not, which would show you that it's reached all three things. The point I like to make here is whatever you're doing in your office, and we all have different practices, but I think that the big point I like to make is document. Make sure you're putting down what you're doing and keeping track of it. Soak times. How long are you soaking things for? If you're testing with Cydex strips, put down your results of your test strips. If you're running an autoclave, have results of your autoclave. You need this stuff to know that things are being done properly. And I think one of the points that John had brought out, he said, you know, I've got somebody who trains them and I've got somebody who supervises them. That's important. You need to have both. And as Lori had mentioned too, without the supervision, you know, great employees will still be great employees, but people are people, you know, they're going to slip up on stuff if you don't have somebody who's kind of looking over their shoulder and making sure it's being done. Documentation is a great way that can occur. And I'll share a story, and anybody who's got comments and stories, this is the end of the talk. So feel free to put those in the comments as I tell my story for documentation. We had a case. We do not near as many vasectomies, I think, as John does, but we do a fair number of vasectomies in the office. Vasectomy, sterile equipment. We use an autoclave to sterilize it. Well, a patient came back with a wound infection. Now, John could probably comment to this. Wound infection after vasectomy is not it's not a large number, but it's not a small number either. Patients will get, you know, where the scrotum's at, it's possible to get an infection there. This patient had just a skin infection, comes back, and the wife said, she's with the guy, says, "Are you sure your equipment is sterile?" And, you know, that was her question to us. So I'm like, well, I could tell you that everything is either disposable or run through our autoclave. And I had my documentation board that I went out and got and said, and here's how we certify that our autoclave is working. I said, see this test here that goes out? This proves that it kills even spores. I said, so I can tell you that your husband's equipment was sterile. It's as sterile as the hospital could do. Well, good news is patient's wound healed with normal antibiotics. Everything was fine. But it was kind of nice having that documentation to rely on to kind of put somebody's mind at ease and probably, you know, prevent any risk of them going to a lawyer. Not any risk, I should say, but, you know, the risk. It's good practice is what I'm trying to say.
Yeah.
All right.
Anybody can sue anybody. The other thing is when it comes to autoclaves, make sure you are sending it or putting it through the preventive maintenance, the PMs, on a regular basis. And whenever the PM company comes out, you're paying them. So that's another form of documentation. And they usually put a sticker on the machine itself, reminding you when the next PM is due.
Yeah. Good points. All right, Lori, any final thoughts? Anything from our
we just have some, let's see, I go back here. So
infection risk after a vasectomy should be less than 1%.
Yeah.
So a lot of people are using the Hibiclens, and now they use Hibiclens. They work in the OR.
What's in Hibiclens? We use BZK, benzoyl chloride.
I'm trying to think of the other word for the Hibiclens.
Oh, it's chlorhexidine?
Yes, chlorhexidine.
Yeah.
Yep.
Yeah, that's right. Yeah, we use the BZK wipes just because they're not as messy, you know, staining people's underwear when they leave.
We will use that if they're allergic to the betadine.
Do you?
But we still use betadine first.
All right. In the comments, if you guys want to say how much you liked or didn't like this format, let me know. I think we've done this now for a couple of weeks, and I enjoy it. It's fun to be able to go back and forth on people's thoughts, and we got experts. I may as well utilize their expertise.
Well, I think, Vic, this is kind of like, you know how when you go to scientific meetings and then the presenter gets on stage and talks about stuff, and then you get the most value from the discussions that ensue outside of the actual presentation.
Absolutely.
This is exactly what we're doing.
Yeah. Yeah. Well, great. I appreciate you guys all joining me. You, Lori and John. Couldn't do this without you. Wouldn't be as much fun, that's for sure. And I think this was a lot of information. It's the most comments I've ever seen come through on the comment box.
I know, I'm trying to keep up.
Audience, you're doing a great job. I do have a couple promos I'm going to put out there. So here's my first promo for Bootcamp. Rally for Bootcamp, our monthly meeting where we decode the art of video streaming. Enlist for tactical sessions on cutting-edge techniques, intel on industry shifts, and a chance to appear live on my streaming program. Gear up, stay sharp, and gain the upper hand in the streaming battlefield. No experience necessary. All are welcome. There's a limit of only 10 live participants, the first 10 to register, and 200 spots additional available for watching. Questions can be submitted via the comment box. This event will not be streamed on any social media platforms, so no worries about appearing live online. And it all starts September the 4th at 7 p.m. Central Time. Be there to join us on Boot Camp. All right. Hope some more folks will join us for that. You go to euronurse.com and you'll be able to sign up for Boot Camp. This first episode, I've already got the format set up, working on my slides on it. It's going to be on microphones. What's the best choice of microphones for doing podcasting? Because it does make a huge difference what you use and how you sound. We're all using different microphones and we all sound great on this show. But that's what Boot Camp's going to be about. If people that are interested in getting into this format, doing podcasting, we're going to discuss all sorts of things. You don't have to be in healthcare. You could just be interested. So we'll see who all signs up for it. I started the advertisement and I've already got a few people signed up. So be sure to join us. I did look at the comments as I was going through the play, and you guys seem to really like that format. So I think we'll be doing more of this in the future. Cause this, like I said, for me, this is a blast. And as John said, it's just like, when you go to a talk, you learn more from the conversation around the talk sometimes than you do the talk itself. Now we're getting it. Today's the last day of August, which means we're going into September. So I decided I'm going to do something on EuroNurse just for that.
September is Prostate Cancer Awareness Month, a crucial time to focus on raising awareness about the importance of early detection and treatment. This month, EuroNurse is dedicating its entire educational program to prostate cancer, offering valuable resources, information sessions, and expert talks to help healthcare providers stay informed. Join us next Saturday to kick off prostate cancer awareness.
All right. So I'm going to kick it off next week with a show devoted. The whole month's going to be devoted to prostate cancer. So I want to go ahead and get you guys out there to start thinking about what you're doing for Prostate Cancer Awareness Month. Put those in the comments. You can use the Ask Euro Nurse to send me information about what you're doing. And we're going to start kicking it off with what things go on and what kind of awareness there is out there. So September is going to be Prostate Cancer Awareness for EuroNurse. All right. Hope you guys have a great holiday weekend. Enjoy your extra day off. No work Monday, right? All right.
Well, when you run
Thanks,
your own
Lori.
practice, when you run your own practice, there's no really off day.
We'll all feel bad for you on Monday, John.
Yeah, I'm enjoying my weekend. So
Have a chicken.
Most days are a holiday, so I don't really mind either. I don't notice the difference. I'll be off, but
I love it.
I got the whole week off next week, so that's a bonus for me. All right, well, thanks everybody for joining us. Join us next week. We're going to kick off that Prostate Cancer Awareness Month here on EuroNurse. See everybody next week.